Triglycerides, the underestimated risk. Fat tolerance test, the future of residual cardiovascular risk diagnosis. If you had a patient with normal LDL, treated with statins or not, and fasting triglyceride levels of 150 to 180 milligrams per DL, would you prescribe a treatment to him? Probably not. This, of course, is more true if you had a patient with fasting triglyceride levels of 90 to 150 milligrams per DL. You definitely would not provide a triglyceride treatment. However, both approaches include an error. And the error is 1. The underestimation of the correlation between triglycerides and atherosclerosis, and 2. The weakness in dynamically measuring triglycerides' actual level. First error. There is the impression that triglycerides, as large molecules, cannot penetrate the blood vessel walls and therefore do not cause atheromatosis. This approach is inaccurate, because as triglycerides increase in blood postprandially as chylomicrons and VLDL, the human system transfers them to LDL and HDL in order to metabolize them. When LDL is saturated with triglycerides, they break down and become small and dense LDL, which do not only promote atherosclerosis, but which are also more toxic. Also, after the dissolution of chylomicrons and triglycerides, triglyceride remnants are created, remaining in plasma, and they penetrate the blood vessels as well as causing atherosclerosic lesions. Conclusion. When triglycerides are increased postprandially, small, dense LDL and triglyceride remnants are created, which are atherogenic. And therefore, triglycerides should be evaluated as an important atherogenic factor. This is confirmed by a number of studies, including the Framingham Heart Study, Copenhagen City Heart Study, Asia-Pacific Cohort Studies Collaboration, Hokanson-Austin meta-analysis in 17 clinical studies, where 46,413 men and 10,864 women participated. Second error. Measuring fasting triglycerides in the morning, we gather wrong information. Because triglyceride levels are rising postprandially. During the day, we eat meals or snacks, each containing 20 to 40 grams of fat. After each meal, triglyceride levels increase. Moreover, if the body does not have time to metabolize the previous meal, triglyceride levels increase even more. Therefore, during the day, triglyceride levels are fluctuating considerably at several levels. Morning measurement is unable to detect the dynamic variation of triglyceride levels during the day. It's something like diabetes mellitus. While a patient has a normal fasting glucose level, a glucose tolerance test is required in order to determine a problem with sugar metabolism. With triglycerides, we have the same diagnostic problem. Because their level fluctuates during the day, proper measurement requires a dynamic test equivalent to the glucose tolerance test. This test is the fat tolerance test, which detects the pathological postprandial triglyceride levels. Studies have found that patients with fasting triglyceride levels of more than 90 milligrams per DL with cardiovascular disease, hypertension, type 2 diabetes mellitus, obesity with a BMI higher than 27.5, metabolic syndrome, but also women after menopause, elderly over 65, and smokers present pathological postprandial triglyceride levels. Therefore, patients who belong to any of the above categories having fasting triglycerides of only 100 milligrams per DL are very likely to have pathological postprandial triglyceride levels, and they are under high cardiovascular risk. These patients, who measure their triglyceride levels only in the morning, remain undiagnosed and therapeutically untreated. It remains to be seen whether early diagnosis of pathological lipemia and subsequently more aggressive treatment will reduce cardiovascular risk. D. genomeres, Advanced Medical Research.